Welcome to today's class. Today, we will be discussing prioritization and delegation. Both of these topics are interdependent on each other. Like you cannot discuss prioritization without delegation, and vice versa. So most of the students fail doing the prioritization questions because they focus on diagnosis. Like if they see heart attack, they will see it as a priority. Even if that was 3 days ago, they do not see the modifying phase. They do not see the deterioration of the patient. They do not see it's expected or unexpected. They see some heavy diagnosis and then boom, they select that. So in today's lecture, you will be ending today's lecture while getting the things done. You will not be guessing the questions from today onwards from the priority and delegation. So starting with why do we people fail, right? First, we will have to see the most like common failures of the students, the way they fail the prioritization questions. So first of all is diagnosis. As we already discussed, they will see a heavy load in diagnosis with very poor morbidity, mortality, etc., and then they will choose that. No, that would be a wrong choice. So they will also choose the pain. I mean, pain is very terrible, right? You will always prioritize your pain, but if someone is dying, the pain can take a back seat. And they also use age as a tiebreaker. If you see two people with similar condition, you cannot decide if it's there is a tie amongst your questions. So you see who is younger or who is more older, I will give prioritization to that. That approach is completely wrong. The NCLEX does not care about age specifically. Also, they also care about emotions and drama. That patient called 4 times, that patient already got this, the family is visiting them. You do not care for the emotions of the patient here. You have to be a safe nurse. And they also ignore the instability signs. If there is like, I'll give you the example here with the priority. If there is like pain for the patient from kidney stones, he's screaming, he's loud, he's distressed, his family called, his doctor called, and then there is a patient who just had a confusion. He had a UTI. Just assume there was an old person who presented with UTI and now is very quiet and having some confusions. So you will prioritize this over the pain because that's a new onset. There is no instability, instability, and you will choose that. The neurological change is a sign of pure perfusion. So that's CAV. You will have to choose the circulation over here. There is deterioration in the patient. So let's boil down what NCLEX thinks. It's not like your ward. NCLEX is a fantasy world. There is a hospital which there are numerous staff available, numerous doctors, all the medications and everything. It's take it like a fairy tale kind of thing. So you will see, you will be asked a question, who is the sickest? No, you do not prioritize the sickest one. You prioritize who will deteriorate if nothing is done. Sit like a, you are a nurse on a duty and you have a condition that you will be seeing only one patient, and you have to see only one patient, and then you have to prioritize, okay, if I do not act upon here, he would die. You do not anticipate, you do not see the future, you just live here and now and tell, if I do not do this action or if I do not flag that, will that patient die? So that's prioritization boiled down to you. So there is a exam trap here. The pain is psychosocial. You know the Maslow hierarchy. I will discuss it later into the further slides. So it's a like comfort. It it is a priority, but not as much as priority as a physiological or a safety. So NCLEX always prioritize safety. They do not care how good nurse you are. They only care how safe nurse you are. So NCLEX prioritize deterioration, not drama. So that's like, I will having the footnotes onto the every slide for you to basically have a boiled down idea of every slide. So starting with the algorithm, if imagine if there is like a set algorithm for you, you will see that, you will follow that, and boom, all of your prioritization answers are getting good. So starting with that, is anyone dying? Is there immediate danger to that? Is there like high tension live wire hanging on to the patient? The patient just had a fall on a sword. So that takes the priority over airway here, like very imminent, very prominent, very obvious danger. And then the regular old ABC, that's pretty good. You must all be aware of the following the ABC. And then there are the tiebreakers. I usually call them the tiebreakers for that. They will tell a set about the options because the questions are pretty confusing, to be honest. So is it acute or chronic? The acute gets the priority over here. See it like a IPL scores. Like every team has some scores and there is a tie. Then we see the run rate of the teams, right? So see it as a tiebreakers. Is it expected finding or not? Patient is having pain after surgery. Is it expected? Obviously it is. So is the patient stable? Will that patient deteriorate? Is that patient deteriorating? Are vital signs good? And then is there any immediate need of RN? If you're working into the ward, just think of it. Can I send a nursing student to that patient? Can a ward boy do that? Can I send my junior nurse to that? Or I have to get up and see that patient? So that's the algorithm for you. Trust me, if you just memorize this algorithm, you will be able to solve half of the prioritization question. So let's just have a clinical example over here. So patient with a post-op history of day one having a pain 6 out of 10 versus a patient with a day one surgery with new onset of tachycardia. So whenever you hear word tachycardia, associate with blood loss. So what do you think, uh, out of this, which patient needs more care or more attention or more prioritization? Obviously, the patient with tachycardia. So let's discuss the common exam trap because these NCLEX people, those are like very mischievous people. So do not pick the loudest, the glamorous option. Do not just pick the heart attack over everything. So hypoxia is the killer. And just have the example over here. And usually the memory trick here you need to work over is ABC, airway, breathing, circulation, that's all. And then urgent, systemic, and acute. Following this, if you cannot remember this, just remember this one. I have just made easy for you. So winding up this slide, so safety over comfort. Again, that we discussed the pain, acute over chronic, like recent over many years, unstable over stable, expected over unexpected. I will just discuss down all of these. And systemic versus local. You need to learn this one too. You will not be failing any prioritization questions if you just learn these two algorithms. So starting with the ABC, if there are words like stridor, tongue swelling, obstruction, think of no oxygen, no breathing, and that's the airway. You do not have to read half of the options if you see these words right there, and if you read the question carefully. And then breathing. Breathing involves the exchange of gases. So is there like respiratory distress, hypoxia? Is there any impaired gaseous exchange? Then you have to take it as a second priority. And then the circulation. Is there any shock, hemorrhage, any perfusion failure, something like that? So let's just think about an example. I will be giving example in every slide. So just you have something to hold upon. There is a patient with stridor, and then there is a patient with BP 70 by 40 who needs urgent care. According to NCLEX and according to real life also, The patient without an active airway, you cannot oxygenate him. So stridor means compromised airway. So that guy will need some assistance first. The patient with BP 40 by 70 is still breathing. His airway is still patent. So let's discuss how NCLES traps you. So student will choose the circulation, like they will have a seat like, oh, hemorrhage, blood loss, but they will ignore the airway because blood loss is alarming. They will see pool of blood, or there will be a question like patient bed sheet is soaked with blood, and they will choose the patient with the low BP, but you will ignore the stridor. It is one part of the airway, so you do not need to ignore it. So just for the students who have some trouble like in memorizing stuff. So if there is no oxygen, no life. Moving on, then there is you need to like start a difference between airway and breathing. Airway is something that is getting our gases inside our lungs, and breathing is the actual exchange of the gases. So think of airway as a pipe, like a straw. If there is any blockage in straw, if there are any kinks in straw, you cannot suck it. So think airway as a straw. Is there is like stridor, choking, obstruction, tongue swelling, trauma, any anaphylaxis, any bee bite, any like physical obstruction into the mouth, or something like severe facial trauma, any burn patient, something like that. So that will involve the airway. Learn about this, because if you see these keywords, you would definitely know the NCLEX is now talking about airway. And then we are talking about the breathing. So can oxygen get across? Is there a possibility of gaseous exchange, or is there impaired gaseous exchange? So these are pretty obvious. Every nurse would know these signs. Low SpO2, tachycardia, tachypnea, dyspnea, respiratory distress, cyanosis, hypoventilation. So these are the signs of the gases are not effectively exchanged. So you need to learn this difference. I'll give you the example over here. So there is a stridor because of some allergic reaction, and then there is SpO2 of 82. Who will win? This is a trap question. I will discuss the trap here too. So the winner would be the patient A with stridor. If there is kink in pipe, you cannot have oxygen. This patient's SpO2 will drop down more faster than the patient's B because there is no oxygen versus there is impaired exchange of gases. You understand my point? So there is a little memory trick I made for you guys, like from plumbing purposes. Fix the pipe, fix the straw before worrying about the water. Getting me? So if you memorize this one, you will never be confused between the airway and breathing, because NCLEX is very brutal over if you cannot differentiate between airway and breathing. So coming on to this, I'll explain one. The students will often choose SpO2 of 82 because number is low and alarming. And if you see that monitor is buzzing, you will definitely choose that one. But if airway is blocked, it doesn't matter how much oxygen you will push into that. If there is physical barrier of oxygen not getting into your lungs, then how gaseous exchange will happen? So airway is always over breathing. ABC is the term, but you need to understand the difference between airway and breathing. So only you will be able to prioritize the patients. And again, I am discussing the acute beats the chronic. Something that is happening right now beats something that has been happening for 10 years. So let me quickly discuss the red flags about the quick, like the acute. Think of it as a quick ones. So there is like new, sudden, worsening, unexpected. These are the keywords used by the NCLEX. So do the comparison, like if there is like chest pain, new confusion, new weakness, new shortness of breath, see this keyword new, that refers to acute. And if there is like chronic, there is like something happening for 10 or more years. The patient, most common one is patient with the chronic COPD with SpO2 of 89. That is chronic, baseline, and expected. We will be discussing the expected ones also. There is like confusion, but that patient is of dementia, so that's expected. The old stroke, stable AFib. Afibrillation is stable. As long as that guy is getting anticoagulants, AFib is never the priority. It is again very alarming sounding diagnosis. Arterial fibrillation, that patient gonna die? No, no, that patient not gonna die anytime soon. So let's quickly discuss if there is like AFib versus sudden dizziness. That patient is feeling funny out of nowhere. So AFib is a like very long-standing rhythm. Sudden dizziness suggests like there is something like hemodynamic change, something wrong with the brain, some stroke or something like that. There must be something happening new, acute, sudden. So just to for you to memorize the whole slide, change kills, baseline doesn't. Just like speed, changes kill. Focus upon to the keywords. So the trap that NCLEX uses for is that patient will choose the worst diagnosis like stage 4 cancer, heart attack, or something like that, but will ignore the new symptom that might be more worsening. So prioritize the newest problem because that problem has not been fixed, that has not been discussed. There is no chatting about that. And if there is like you also be doing that triage thing. If that patient is bound to grave, let it be. Save the patients or prioritize the patients who could be saved. So again, expected versus unexpected. The chronic and acute and expected and unexpected like overlap on each other because there is something expected into the chronic illness. Very predictable. Patient had a surgery, he's having pain. Not a priority because that's expected. There is like mild bruising after RSA, or that patient is taking heparin or warfarin and there is visible mild bruising onto his hands. That's expected. There is like it's usually tested by the NCLEX. Migraine photophobia sounds like a big term, but it's very expected and predictable one. So these are the signs of known diagnosis. If anything is known, you will fear less about it. And then there are unexpected, the critical ones, sudden onset of confusion, new weakness. Again, that previous slide that we were talking about, acute beats the chronic, unexpected hypoxia, active hemorrhage, respiratory depression. Like take a snapshot of this and make a mind map. If there is something predictable, if someone is having pain after surgery, that's expected. Someone is having sudden confusion after surgery. That's something I should look into. So there is a example for you. Patient who is post-op having 8 out of 10 pain versus patient with a sudden confusion. Who will you see first? The patient with sudden confusion because pain is expected after surgery. He just had his guts open. Why would you not expect him to have pain? So student often pick the high pains because those are like more dramatic. Nobody wants to be in pain, right? But more than that, nobody wants to die. So complications beat complaints. Another memory trick for you. So we will be discussing stable versus unstable. Who is stable? Normal vitals, s- like baseline findings are good. Expected symptoms, someone with COPD having SpO2 of 89, that's expected, that's not alarming. Someone who is ready for discharge, but there is no modifying phrase like ready for discharge, but is having LOC. So will you discharge that guy? No. There are no recent changes. Very boring patient to be said. Some chronic illness, long-going illness, but it will be priority the unstable ones who will have altered sensorium, airway compromise. Again, airway will not leave you alone, right? And active bleeding, respiratory distress. Just note down these things. This will be able you to differentiate between priority and who are stable. And again, with the example, I will just make the things perfect for you. A patient who is ready for discharge, no modifying phrase onto that, versus patient with new confusion. The new confusion takes all the priority over here. The patient who is ready for discharge can wait few minutes or few hours more, but this patient with new confusion cannot wait. So memory trick for it, stable can wait, unstable can't. So physiological instability is the thing that NCLEX is searching for. They are searching for safe nurse who will see physiological instability and act upon it. So we will be discussing about the actual problems and risk problems, something that is really happening right now and something that will happen in near future. Weirdly, NCLEX wants you to act right now. Existing harm, do not anticipate for it. Live in today's world, right? Risk for aspiration, risk for hypoglycemia, risk for bleeding. They all are risks that might happen, that may occur in future. The potential harm. But if there is something like actual aspiration, actual hypoglycemia, and actual hemorrhage, then you should be able to take that. This is one of the easiest one to pick up on. Something happening in future? No. Something happening right now? Yes, go act upon it. So reality beats the possibility. Again, I will teach you with example. Patient with false risk due to weakness. That's future prediction that he might fall. And then there is a patient who is currently on the floor who has already had a fall. So who will you look after first? The patient who is already on to the floor. Check him, get his vitals, do his full body examination. So yeah, that's the best example I could find, and you will be able to resonate with that. And again, here comes our Maslow hierarchy is used to break ties. If you'll all be aware of the Maslow, I will not be going over this very harshly because it's being studied and discussed very along. So, memory trick for this is people must survive before they thrive. If you are living, then you can have self-esteem, then you can experience pain, and then you will go home, right? So oxygen, food, and water, these are the baselines. These must to be addressed by the nurse as a priority. So let's go with the clinical example. Breathing problem versus anxiety. He will not be having any anxiety if he is not breathing. So breathing takes over anxiety. Hypoglycemia over loneliness. If he turns into the coma, he will be as lonely as he is right now. So hypoglycemia takes over the loneliness. So physiological needs take over everything. And they will not check upon like safety and security, love and belonging. They will, NCLEX doesn't care about it. They will see physiological needs compared to all of the pyramid above. So if you nail this one, you do not have to memorize all of it. So there is a another rule here. If the ABC does not apply, look for the mass law. First, you have to apply the ABC. That is the golden rule book. Now, whatever slides we are discussing, these are tiebreakers. Follow the ABC, and if you do not see anything like, oh, both patients are having airway problem, oh, both patients have circulatory collapse, and then you will see these. So another point, add pi. That's pretty much always we have learning about this. We have made all the nursing assignments revolving around this. So first you have to assess the patient by yourself. You do not rely upon the LPN, RPN, UAP, or everyone. You have to see the patient by yourself, do the assessment, and then make the diagnosis. So just follow this process. So there is a clinical scenario. The patient becomes suddenly short of breath. So there is a option, increase the oxygen or call the like care provider or call the doctor over here. So what you will do, you will assess the airway. Is there like is that guy ate toffee 2 minutes ago and that struck onto his throat and that's why he is having shortness of breath? You will never know if you will never assess the patient. Assess the patient and then you will formulate the diagnosis. Do not act upon until you get all the information. But when it does not apply, when you will skip the assessment part and you will get your things done hands down, when there is a cardiac arrest, severe airway obstruction, something like choking, something like anaphylaxis. So these are the emergency procedures, the emergencies where you will not make the nursing assignment. You have to act fast and quick. Uh, If you do not act, the patient will die. So memory trick for this would be do not fix what you haven't assessed. You do not know what is wrong with the patient and you are here fixing that. Would you be able to do that? No. So NCLEX is very much aware about that. So they will be testing that. Coming on to the questions, like how will you solve them? If you have four options and three of them are doing something like looking at something and the assessment is the answer of the winner of the 90% of the time. Again, I will simplify it for you. Like if there is option, there are four options, and in each option there is always like give this person this, call the doctor, or raise the bed end, or something like do a respiratory assessment. So assessment will win first. So and now we will be discuss the post-operative patients. The danger zone usually is the fresh ones, the people who have like 12 hours over of the operation. There are not a priority usually. If there are no unexpected findings, there are no new findings that we have previously discussed. So any patient that less than 12 hours of surgery is a priority because that's critical period. And again, this is a tiebreaker. This is not a rule. So patient with 3 hours post-op and patient with 3 days post-op. Who will get the priority? The patient with 3 hours post-op. Because if everything else is equal. So new surgery, new danger. You never know. I will just pause over here. So starting with that, if you have like critical risk zones, if there is like hemorrhage, shock, airway, hypoxia, see, we keep coming to ABC over every slide because that's the most important part. So, and what we have discussed over here is fresh post-op patients deserve more special attention. The nurse will do the first set of vitals. The nurse will monitor the patient first, and then she will delegate all the stuff to other counterparts. So that's the thing. I have pretty much more slides made over for me, and these are all the slides. Those are made by myself. And for now, the recording purposes, I think the 20-minute mark is over. So I will quickly show you all my slides, and I will just thank you for the opportunity provided to me to give my recording as a testing tool to be a part of your change. So myself, Simarpreet Singh, I am a registered nurse, and I have recently acquired a New York nursing license. And the fun part is I am currently doing MBA in hospital management. So that's all from my side. I hope you liked my short demo of the class. And if you need, I will give the full whole demo. Basically, I have prepared the whole lecture for me with the mind in mind for like 1.5 hour class, because I will be discussing over and everything, and I will include the priority and delegation over here. So that sums up my lecture. Thank you so much. I will just stop recording right now.